Welcome everyone for today's webinar. Today's webinar, Acute Stress, a Normal Response to an Abnormal Event, will focus on the symptoms of acute stress and how this normal response after a traumatic event differs from post-traumatic stress disorder. Today's presenter, Dr. Kamin, will share with us his experience as a physician providing medical support for law enforcement. Dr. Kamin is an emergency physician, an associate professor of emergency medicine and EMS program director at the University of Connecticut Healthcare. He also serves as the medical director for the Connecticut Department of Public Health Office of EMS. Dr. Kamin is the co-chair of the Committee for Tactical Emergency Casualty Care after having served as a guidelines committee and board of directors member. It's my pleasure to welcome Dr. Richard Kamin.
Thank you very, very much. Hi, good morning or afternoon as it is, depending, I guess, on where you are. But absolutely pleased to be here, and thank you for the lovely introduction and the opportunity to present. Again, I'm Rich Kamin. I am hoping that I'll be able to get this to, there we go, very good. So we're going to be talking about acute stress, which was something that I knew very little about until I got to a very important event in my career, and that's what drove a lot of what we're talking about. I have no disclosures financially. I do want to very specifically thank a woman who works down in the south end of Connecticut, and her name is Karen Alter Reed. She works with the Fairfield County Trauma Recovery Network. You'll see some branding on some slides. We have worked together making similar presentations, and she has, I have all of her permission to use some of the slides that are branded, but Karen has been an important ally, as have a number of other folks working to address the, not only the preparation, but the mitigation and the response to trauma. Okay. Wonderful. So we're going to talk about acute stress and, very importantly, how it differs from PTSD. I'd like to try to helpfully get folks to understand how acute stress can manifest and how we might be able to address it more efficiently, and then talk about some treatment options for acute stress and PTSD. This is all born out of my experience, and by December of 2012, I had been training and working, specifically providing medical support to law enforcement, for over 10 years at that point. I trained as an emergency physician. I worked at a level 1 trauma center. I had done training specific to providing medical support for law enforcement, tactical emergency medical support. I really thought that I was prepared. And when I walked into Sandy Hook, which was an event like, unfortunately, other events, that it was hard to anticipate, and the person trying to do harm chose a softer target, in that they chose a school, and that the shooter killed himself very shortly after first contact with law enforcement, and that there was a lot of resources available, even though Sandy Hook is Newtown is a very, very small community. There were a lot of response and rescue EMS resources available, but unfortunately, very, very, very few patients that needed to be attended to. And for the sake of this, the length of the investigation after Sandy Hook only really served, unfortunately, to compound a lot of the trauma and the interruption that this was providing to folks, because it was hard to get closure with the ongoing investigation. And, that's even putting aside some of the ridiculousness where people were putting out there that they thought that the whole event was simply a charade and that this was a political attempt to drive an agenda. Even that taken aside, which was also kind of ridiculous. So, like I said, despite my training, level 1 trauma center, 10 years in, working with law enforcement, multiple responses, nothing, what I realized, nothing could prepare me clinically or emotionally for what I experienced at Sandy Hook. And it's important so that folks need to understand, I'm not going to talk specifically necessarily about the event that I encountered, the images, the injuries. What I'm going to talk about is more global. So I want to, if anyone's concerned about that, they're not going to have to live through that. I tell people, quite frankly, that a lot of the work I've done around my response to the event has helped me maintain perspective on this. This is important so that when I wanted to think articulately about Sandy Hook and my experience, I was able to do so, but that it also allowed me the distance and the ability that I needed to talk about this without getting overly activated and in order to maintain perspective. What I was unbelievably lucky about was that despite the fact that I turned out had not been prepared adequately for how one might respond after being exposed to an event like that, I was very, very fortunate. I had good counsel on the evening of the event when I returned home. And as I was driving home, I was terribly worried that I was going to be forever affected by this. I speak frequently of my wife, Susan, who's an unbelievably supportive individual, but still reminds me that she married a physician and not a police officer, not a firefighter, and that although she has great respect for what I do, she worries about me every time I get out of bed at 3 o'clock in the morning to go serve a warrant or do some action with the teams that I work with. And after I was at Sandy Hook, very quickly, I realized that, this was going to be something that I couldn't possibly avoid being affected by. And I was kind of worried that I had been broken. And I got home and I was already having intrusive thoughts. At the time, I had 2 children who were Sandy Hook age. And I was unfortunately already seeing intrusive thoughts regarding having my kids' faces on some of the other children that I had taken care of today. I was shaken and concerned, and I got a call from the gentleman who's the chair of emergency medicine at UConn. His name is Rob Fuller, and Rob has an extensive experience doing disaster work, had been at Banda Aceh, had been in Haiti after the earthquake, and had spent a lot of time around a lot of pretty significant events, and very quickly checked in with me and very matter-of-factly said, well, yeah, Rich, you should expect to have these intrusive thoughts. It's going to be hard to sleep, hard to concentrate. You're going to be a little more labile than normal, which if for folks that know me, having me be a little more labile is not a particularly attractive thing, but nonetheless good to anticipate. And he said, it's going to be hard to concentrate. It's going to be hard to sleep. What I want you to do is exercise every day. Don't use any drugs or alcohol to deal with what you're dealing with. You got to make sure that you have someone to talk to and you're talking to the right folks. And I'll pick you up tomorrow morning at 7 o'clock and we'll go exercise. And, although it didn't sink in at that point, Rob really was the first person to give me an understanding of what a normal response to an event like this would be. The next morning, after Rob and I worked out, actually, I went to a debrief with the FBI. And the folks who were there running that debrief from said ostensibly exactly the same thing that Dr. Fuller had said to me. And it's always very reassuring to me when I hear people telling me things in a consistent fashion. And there was just no contradiction. The folks from the FBI were saying, you guys had just gone through a very unique event. And we had some opportunity to debrief the event and talk to folks about what was troubling. We got a little bit of time to understand that we were all going through a very similar event at that point. And again, it was reiterated that a normal response to this is having intrusive thoughts, hard to sleep, hard to concentrate, being labile, et cetera, et cetera. And then the other real blessing that I got was Rob Fuller kind of excused me from clinical responsibilities. What he told me was, you take as long as you need, but I want you to at least take a couple of weeks. If you're ready to come back sooner, that's fine. And if you need longer, that's fine. We'll figure it out. But having that taken off my plate, knowing that I wasn't going to have to go in and provide clinically in the emergency department was a tremendous relief and ended up being tremendously helpful. So, like we talked about, I got my first exposure to the fact that there is a typical course of symptoms that is frequently experienced during or immediately after an exposed trauma. They typically last for a couple of days and importantly resolve within 3 to 4 weeks. And it's not PTSD. This component of people's response is not post-traumatic stress disorder. And I can't stress this enough, that understanding this gave me an enormous amount of relief, understanding this, that I was able to detach a little bit and watch this unfold inside of me going on while I was watching it happen was very interesting, but it was a great relief to know that I wasn't broken. That was reminded to me over and over again, that I did not have to walk with a limp for the rest of my life after Sandy Hook. I might very well be different, and I tell people commonly and frequently that I am definitely a different person after Sandy Hook, but I don't feel like I'm broken. I was told very explicitly about what I should do in regards to taking opportunities to debrief, and if I didn't want to take part in formal debriefs, that it wasn't mandatory, but that I absolutely should think about the importance of talking to folks that I trust and may be able to understand me and provide me counsel. If there was ever a time to take care of myself, it was now. Exercise regularly, sleep and eat as best as possible. Again, avoiding drugs and alcohol. And if need be, take advantage of counseling opportunities. And then importantly, what to watch for and when to get more help. You know, in other words, the moments where the sleep is not working for you and you're getting exhausted, you might have to talk to someone about getting some medication to help you sleep. And if you're having intrusive thoughts that are just too much for one person to handle, then, or it's not resolving, you know, any of these things that seem out of the ordinary should be a key to get folks to get some more assistance. I ran into a counselor that I had actually seen for some marriage counseling with my wife. So my experience with Sandy Hook was not my first exposure to counseling. I was in the end very grateful for that, and that I was open to it. And I ran into this woman that had seen my wife and I and provided some very successful marriage counseling for us. And we started talking, and we met on the street, and she just asked me how I was. And it was about 2 or 3 weeks after Sandy Hook, and I'm kind of a, you know, not a guy that does a very good job of, you know, hiding my emotions. So I told her I wasn't doing very well. I had just been through this experience, and she looked at me and she said, well, you know, for what it's worth, I know I saw you and your wife as marriage counseling. What I do for a living, however, is really trauma. What I specialize in trauma. And if you'd like, I think I could offer you some help, because what I specialize is in this one particular intervention called EMDR, which is eye movement desensitization and reorganization. She assured me that she thought it would be effective. She also told me that it was very protocolized. It was not traditional psychotherapy, or at least what I thought about traditional psychotherapy. So I wasn't going to have to recount when I stopped breastfeeding or was forced to stop breastfeeding, and when I finally potty trained, etc. And that she also assured me that it was going to be good at any point after the exposure, so that doing it sooner might provide me relief sooner. And if I wasn't ready, that I could come to see her at any point, and she thought she'd be able to help. And in the wake of this, my experience with all of this, I really started asking people to keep in mind what turns out to be a very real effect that these kind of crisis events have on responders. And I realized that even though I was as engaged and committed to being a responder, I had not been taught properly about what to expect in the wake. And I also realized that as I went around locally and regionally and sometimes nationally trying to teach folks about how to respond to critical events, active shooters, other intentional acts of violence, natural disasters, again, largely because of my work with law enforcement and because of the work that I do with the Committee for Tactical Emergency Casualty Care, I became very committed to making sure that folks understand that you have to take this component of the event into consideration. I really do think that we are empowering responders by helping them understand what's a normal response to an abnormal event, and also helping them advocate for resources that they would need before, during, and after an event. The response to a trauma can frequently be adaptive in the moment, but what we do in response to whatever it is we're trying to mitigate is frequently adaptive. But unfortunately, it's the remnants of the experience that remain and at sometimes become dysfunctional or harmful. And when this happens, and there are components that remain and can't be processed, there's typically too much for one person. They become overwhelmed. It's, presents itself with a lot of the symptoms that we've spoken about, but unfortunately, the event can get frozen and frozen their body, their brain, unable to process what happens. And this is actually not unique to any one sort of trauma. And again, it's interesting how almost universally applicable at least some of this is when people's response. And now that I've started thinking about it, and I take a look, and I want folks to have an understanding that, as I talk to my colleagues in the emergency department and folks who are firefighters and EMS providers, police officers, social workers, keep going, I realize that, folks are having experiences like this, and they're not able to very well talk about it, or they're not able because they don't really know how to describe it effectively, and they don't know the language around talking about it. So again, important that we all get comfortable. Trauma is again an event that could be experienced directly, witnessed, or retold. And I think it's important that it understand that it causes ongoing distress. And sometimes these things are single events, and sometimes they're accumulated experience. And sometimes it actually is not necessarily the experience of the event themselves, but maybe the institutional response around that event. I'll tell you that the day after Sandy Hook, I was having coffee with Rob Fuller, and I overheard two people talking about how they can't watch TV anymore because they just can't stand to listen to anything more about Sandy Hook. And I got so angry in the moment, the morning after Sandy Hook, that somehow these two people could, be so frustrated and upset after they had had what I thought was such a detached experience from Sandy Hook. And at this point, I was still looking down and seeing blood on my boots. Rob looked at me and he said, so, Rich, before yesterday, what was your 10 out of 10 on the horrible scale? And I said, well, I guess, for the most part, it was 9/11. I couldn't imagine anything worse than that. And he said, okay, he said, that's mine as well. And he said, now, what's your 10 out of 10 on the horrible scale? And I said, well, it's Sandy Hook. And he said, correct. So your meter got reset. I said, mm-hmm. And he said, everyone else's meter, or a lot of other folks' meter, got reset too. And a lot of those people didn't have to go to the event, didn't have to experience, didn't have to have their hands on the victims. All they had to do was be exposed to it on the television. And maybe those folks have kids, or they know someone who has kids, or they have a niece and nephew. I mean, it's just important to understand how really affected people can be just by being exposed to these things. People talk about big T's and little T's. The big T's are pretty obvious, Sandy Hook and things like that. The little T's are things that most people don't even think about frequently. Those are the routine calls, the routine illnesses, the routine patients, the routine events in our day-to-day stuff. And eventually, unfortunately, they can provide a lot of accumulated trauma. And both the big events and the accumulated little events have been correlated with the development of post-traumatic stress disorder. So again, I'd like to define PTSD. This comes out of the DSM-5, and it's legitimately continued disturbance for more than a month. So symptoms that have been going on for more than 4 weeks after exposure to actual or threatened death, serious injury, or sexual violence, and that it could be, directly experienced, witnessed, learned about, and that there could be some exposure that is repeated or extreme in nature. But the other thing that a lot of people forget to include in this is that even though everything on this slide is how we define PTSD, there's a critical component to PTSD that has a significant impact on the person's day-to-day living. So even though years after Sandy Hook, I am still having some connection in that I occasionally have an intrusive thought. I really don't have the anxiety or the agitation that I did after the event. But I do have my sense of I've become somewhat hyper vigilant, especially when I go into an elementary school or I'm around a crowd of people. It's true that I'm still affected and my behavior has changed, but it does not impact me in a significant way on a day-to-day basis. And that is a critical component of how PTSD has been explained to me. And again, why I don't feel like I suffer from PTSD. Excuse me. It's interesting. The more we learn about PTSD, we realize that it's not just an emotional or subjective. That there are ways that we're studying now through imaging to actually measure the effect. These are some scans that were done out of the Yale School of Medicine, taking a look at how we might be able to articulate how folks are affected. But very frequently this is an internal storm. Folks suffer with PTSD internally, sometimes very hard to understand or even realize that people are going through it, depending on the individual that's expressing the concern. But no less real, even though it's not an outward injury, and even though we are not necessarily using frequently a lot of the imaging techniques, it's no less real. And that this persistent nightmares or this feeling like the event is still going on, the trouble concentrating, focusing, feeling detached, or startling easily are all very real and very impactful. So again, it's important to know the signs. Folks are irritable, and again, for the folks that know me, you got to understand the person at baseline, because I get kind of irritable. I work as an emergency physician, and sometimes that means I don't get a lot of sleep, and sometimes that means I'm a little more sleepy or grumpy or hard to concentrate. But the folks that are having ongoing intrusive thoughts, folks that are avoiding the reminders or the triggers, I don't mind talking about Sandy Hook. People are frequently apologizing if they ask me a question or somehow it comes up. I don't mind talking about it. The folks maybe isolating in order to avoid exposure. Then again, overindulging or using drugs and alcohol or other modalities, sex, gambling, etc., in order to squelch what's going on, and unusual moodiness. And I think it's very important that for the folks, especially the folks that are kind of overseeing a response, and the folks who are responding, to understand that there are some tools that in addition to understanding what a normal response should be, it's nice to have the awareness that there are some validated tools around, so that either if you think you're having trouble and or you're responsible for some folks that you think might be subject to some trouble, that there are some tools that you can use after an event to help you be objective about how significant the injury they've experienced is. And it might help you, the use of this is to ferret out who would benefit more likely from additional intervention. And the folks that are scoring higher on the tools that we use are typically not within that window of tolerance. And most of us will live our lives within this window of tolerance. Some of us, depending on what we do and how we do it, might be able to perform both during these periods of hyper or hypoarousal. But the folks that are continuously affected are going to find themselves more outside of this window, again, in these states of hyper or hypoarousal. And it should be more indicators that that individual might need some more attention. It's also very important to remind folks about how this will affect you personally, but also will affect very likely all of those who care about you and who are connected to you. I will tell you that my family, both my immediate family and my extended family and my friends, all had a pretty good awareness that something was going on with me. And I was lucky that I was able to be transparent and open with them, and that I hopefully didn't suffer too much disturbance in my relationships with them. Very important, though, to make sure that the families of those we are supporting and the families of those we are responding with understand when someone's having a problem, that they get support as well. Because ultimately, we are a group of herd animals. We as humans inherently kind of organize ourselves around living with others. And that's even for those who typically don't spend a lot of time with other people. And it's not that there aren't true lone wolves in the world. There are, and a lot of times those people are amazingly functional. But for the most part, I think it's reasonable and appropriate to expect folks to want to stay with their own. It's normal for folks to want to connect with folks they think will understand them and have empathy for them and can provide a source of support for them. So in the wake of this, I try to remind people that there's a lot you can do after being exposed, or if you think you're having some of these problems. It's critical to think about who your herd is and stick around with them. Make sure you have access to resources and people who you think will be available to you. Talking to others who've had similar events or similar experiences is sometimes very helpful for folks. Whether those people are professionals or not is not really the issue. It's just having folks to connect with. Again, being very attentive to caring for yourself in regards to sleep and healthy lifestyle. Eating well, reducing alcohol use, reducing drug use, being very careful, even with pharmaceuticals, that if you are having trouble sleeping, that you get in touch with a professional that they can help you with that. Knowing not only what has worked for you in the past, like if you're one of those folks that feels good when they listen to music or play music, exercise, friends, etc., but be open to new techniques. So even if you weren't someone that likes to take advantage of some of these things, that you try to be open and install some of these as new coping techniques in the wake of this. EMDR, I'll talk about a little more specifically, had a tremendous impact for me. I can tell you that in a very short number of sessions, I think I spent somewhere around 8 sessions with the provider that I worked with. It was just life-changing. And it took me from a spot where I couldn't think about the event without getting very, very activated and anxious, to a point where, it still affects me when I think about it. I'm not immune or cold to it, but I'm able to do it without that sense of dread, without that sense of palpitation or fear that used to breed itself when I started thinking about it. So EMDR, again, is eye movement desensitization and reprocessing. And it's really aimed at jump-starting the brain's natural mechanism. The idea that we process thoughts by moving them back and forth from side to side, and that by using EMDR, we can facilitate that process more easily. It can be used as soon as possible, and it's also very good and been shown to be helpful even distant from. And EMDR is actually, they're starting to use it as an acute intervention, actually on scene as some of these responses, not so much to process in detail an event, but to get people grounded to the idea that the event is over, they're safe, and that they're going to be okay. And that immediate intervention component of EMDR is getting more and more used. It's a process that uses bilateral stimulation to activate the brain, which they believe is similar to REM sleep, and that's why they think to some extent it's helpful. And it's again designed to help the brain heal itself. It's been used for more than 20 years, and it's been approved and used widely by a number of organizations that I think we recognize as pretty well established in the field of response, and also pretty well experienced, unfortunately, with dealing with folks who have had trauma. They look at this as specifically targeting traumatic material that has been so, quote unquote, stalled, and that the resolution of this stalling helps kind of move things through the activation of neurophysiological networks and help people process this more effectively to lessen the impact that it's having on them. I like to, first of all, I'm not a psychologist. The only formal training I have in psychology or psychiatry I have from the work I did in medical school, so very little. The work I did in emergency medicine residency and EMS fellowship, so very little. And the work that I've done subsequently, which has been a little bit more, but I am by no way a psychologist or someone that studies this academically. So when I tell you that it's clear that they're not exactly sure how EMD works and that there are a number of hypothesized mechanisms, I want to be clear about that. And it was interesting for me because when the provider who offered me the opportunity to do some EMDR, she sat down with me, and like I said, we had worked together, and I'm a fairly critical individual who doesn't really trust much unless I have the evidence in front of me. And she offered me a number of times to provide me with some of the evidence that she thought was useful. And I had to suspend some of that, just being willing to try to get some help from someone that I knew was using an acknowledged and established form of intervention. This was not experimental, and that she assured me that she thought it was going to be helpful. This is a busy slide. It'll be available when the PDF is available. Again, the why is that it involves alternating stimulation to both sides of the brain through visual, tactile, and audio input. What people think about EMDR, they typically think about watching someone's hands wave in front of a patient's face or a patient moving following a light, but they also use these tactile tappers, these devices that provide tactile stimulation to both hands back and forth, or wearing some headphones or listening to music that goes back and forth from left to right. All have been used. I personally got the most relief out of simply the eye movement, but other people find other ways of doing this more or less helpful. I'm not going to go through the number of different suggested explanations for how it works, but just to understood that it's been fairly well studied, in that there are a number of folks who have explanations that they think explain and have done a fair amount of work around using those explanations and studying them. But it's not just hand waving. It's important to understand that this technique is not something that someone that is untrained and doesn't understand the process should do. It's important to understand that the hand waving or the movement of the eyes is only part of a protocol that involves bilateral brain stimulation. But also what's very important is what precedes the bilateral stimulation, and that's a discussion between the client and the therapist, the provider, about what their trauma is, whether there were earlier traumas involved, and how they were affected, what they are stuck on, and really how they want and what they're interested in addressing. So there's a lot of individualization that goes on, not just the hand waving. And before any reprocessing occurs, before you do the actual EMDR, the therapist goes through a process of understanding what kind of symptoms the patient is having, how they're affecting them, and there's a comprehensive history taking and assessment. I had a compendium of images stuck in my head from Sandy Hook, and before I started doing the EMDR, we took, I think there were 10 of them or so that really stood out for me, and we focused on those 10, and I would think about the image, I would think about how I felt, and then I would do the EMDR. And again, like I said, had a dramatic decrease in the activation and the way the discomfort I was feeling and the subsequent symptomatology that I was having. It has been nicely studied and been shown that it has some effectiveness. They've looked at combat vets with multiple traumas and how there has been good retention. This study is only 3 months after follow-up, but you know, there's good retention for a whole bunch of folks that have gone through pretty significant trauma and then go through EMDR to lessen that. When you compare folks who have had trauma, this one is transit workers who experienced a person under the train or an assault, that the folks who get EMDR have a much greater likelihood of having remission of their PTSD symptoms after 6 sessions. That number of folks that had remission compared to the folks that had no treatment was much greater. And all of this is not to suggest that this is the only game in town. I think some of the most interesting controversy about EMDR, in my opinion, is that people who use this stuff professionally say, well, there are a lot of different cognitive behavioral therapy techniques that you can use to address trauma. And I think that's true. And people argue that EMDR is no better necessarily than some of the other ones. And I don't think anyone argues that. And again, EMDR is a technique of cognitive behavioral therapy is just that. It's another technique. It's another tool in the box. It's what I am personally, had experience with. So it's what I like to bring out and focus on here. We already talked about how EMDR is being used in that immediate assistance. You're hopefully taking the positive effects of EMDR and moving it forward. Again, applying it in a different way than it traditionally is, but nonetheless EMDR. And that this early intervention is going to be stepped care, and that can help you lead to increasing the care that's needed for folks as they go on kind of recovering from their exposure. I don't want to oversimplify this, but I have had, long before I encountered EMDR, a philosophy to interventions. So whenever I start talking to my patients about what I'm going to suggest we do to them to address whatever problem they have come to me about or I have discovered, I like to remind folks that a good intervention or a good medicine is all of these 3 things. It's likely to help, it's not likely to hurt you, and it's not expensive. And depending on the system that you're working and how much insurance you have and how it's covered, EMDR is all of these things. It's been established to be helpful. It's not likely to hurt people. There's an extremely low incidence of what folks have considered side effects from EMDR. And it's an inexpensive intervention, relatively. And when I compare this to a lot of the other things that I see people trying to do to get better, I use chemotherapy as the other end of this spectrum. People have certain cancers, and the treatment regimen we put them on, we're not really sure that it's very likely to help. We know that it's going to make them sicker before it makes them better. And unfortunately, a lot of these regimens are very expensive. So I keep this broader philosophy when I think about interventions in general. I think it's important to keep reiterating that what happens immediately after these events and sometimes during these events matters. Remember to debrief with other people, have those debriefs available, different levels, different opportunities for folks, because one size does not fit all. And we've actually discovered that those mandatory critical incident stress debriefing events that were very popular a number of years ago might actually be doing harm to certain folks. So debrief, have those opportunities available, make sure that you have a varied opportunity for folks. Those coping skills, people need to be reminded of, to use the ones they have and develop new ones. The event was abnormal, not the response you are having. It's critical to remind people that what they're going through is actually probably very normal, and that at some point, although it might become abnormal, it's not PTSD for a while yet. And that there are a lot of qualified folks out there who are good at what they're doing and who actually focus what they're doing on this exact problem. And I speak to the fact that there are very qualified individuals, because what I want people to do is have that list at hand before they have to go out the door. I want people to understand what the normal response to whatever abnormal event we're asking them to prepare for, what that's like before they go out the door. So as they start to experience this, hopefully they don't have to worry that they're broken. And that as they start to experience this, or they're going through the event, they already have the resources that they need set up so that there's no worry or struggle or a rush to find these resources in the midst of going through everything else that they may be going through and trying to mitigate the response or the event that they're responding to. I use this list not because, I mean, I can tell you any of these people on this list, if you're in Southern Connecticut, you're in Fairfield County or anywhere near it, these are all folks who are active in the field. And my point is not to promulgate this list for everyone, but just to understand that a list like this, I think, is a critical component of what every team needs, whatever responder should have in their back pocket, so that when they need them, they have them at hand. This is, in my opinion, as an important part of preparation as anything else. And then I also, you know, we're getting close to the end, and I like to talk about the fact that, you know, the more that we can do left of boom, right? People talk about left and right of boom. And when we talk about left of boom, we talk about getting ready for whatever event we're trying to prepare for, the boom. And then right of boom is our response to that event. And what we're realizing is that if we can help people become more resilient before they are stressed, before they go through a potentially unsettling event, those people typically do better than the folks who are less, quote unquote, resilient. So it's important to recognize in yourself, among the people you're working with or the folks you're overseeing, that this resiliency kind of manifests itself in some pretty identifiable ways. And so resilient people typically are the folks that we see who has caring and supportive relationships. They have high expectations for their own success. You know, they take advantage of those opportunities for meaningful participation. They work on creating clear and consistent boundaries, and they show those life skills that we identify with folks who are kind of put together and doing okay. And, you know, the vulnerable folks look like some of these people, and I'm sure everyone out there knows folks that look like this. I mean, those are the folks that are either, you know, unfortunately affected, or we suspect they're affected by substance abuse. They're folks that don't particularly manage their anger very well. They're unfortunately not well integrated into their community, or they're socially isolated. Sometimes a lot of these folks have chronic illnesses. They're chronically sad or expressing anxiety. They're always stuck in these dysfunctional relationships, and their performance, whether it's school, work, or within the community, is typically deemed inadequate or is at least questionable. You know, we're getting to the end, and I love this slide, because when I think about myself in my most idealized kind of fantastical, so to speak, way, this is what I see. I see myself holding off death, being the only thing between the folks that I'm caring for and whatever it is that might be taking them off this world. But I also always think about these people, and these are my kids, and On the left are my son and daughter, not too long after Sandy Hook. And on the right are my son and daughter not too long ago. And what I realize is that I commit myself to doing what I'm doing to some extent, whether I'm working with law enforcement and trying to support the folks that I know have committed to protecting my family, or whether I am working with EMS or other first responders, because at some point somebody in my home might need help. And if they're going to come knock on my door and answer our call for help, I want them ready. And this is a lot of what drives me. So that is the end of my formal presentation, and I'd be happy to open this up to questions.
Thank you, Dr. Kamin, for that really insightful presentation, and thank you for sharing also your personal experiences. I think that really is useful to the audience to have that perspective when discussing topics like these. So now we're at the point of the webinar where we can open it up to questions from the remote audience, and we are able to unmute your microphone so you can ask a question directly to Dr. Kamin, and then maybe get a little bit of a discussion going. If you're feeling a little shy about it, you can send them messages to me and I can read them out loud. But as I said at the beginning, the preferred way is for you to ask a question directly. So I guess without further ado, we'll lead into that part of the presentation here and take any questions from the remote audience. But before we begin, I did receive one comment during the presentation, so I did want to share this with you, Dr. Kamin. This is from Jean Speck, and she wanted to give a shout out to you from the CT OEMS peeps. So
that's very nice. Yeah, actually, I know that a number of folks in the office, and I thought about them numerous times. You know, when I refer to the people that recognize the fact that I'm at baseline kind of grumpy and irritable and labile, I'm referring to all of them, and they know it. So God bless you all for being so patient with me on both good and bad days.
Well, I messaged her that I'd read that out loud, so I made a note here to do that. I did have a question who I've been also from a participant in the audience going back and forth. Rosemary Anderson had a question, and I'm going to go ahead and unmute your microphone, Rosemary, if you'd like to go ahead and ask that question directly. Your microphone's unmuted. Are you there, Rosemary?
Yes, I am. Thank you so much for the presentation, Dr. Kamin. I really appreciate it very much. My question is around the EMDR therapy, and I'm just wondering, can EMDR help a person to recall blocked memories from being sexually exploited for several months as a young adult?
The short answer to that is I don't know, but I know at least 4 people that I would be happy to get you in touch with who I consider expert that could help answer that question.
That would be awesome.
Yes, absolutely. So my email address is on the slide. I'm happy to have it be used. It's my first initial and my last name at UCHC, like University of Connecticut Health Center.edu. And if you send me that email, I could try to get you connected with someone that might be able to help.
Will do. Thanks so much.
Of course.
And we'll include that email in the correspondence that goes out, letting everyone know when the slides and the recording are available. So that will be also in there. And thank you, Rosemary. We corresponded during the presentation, and I I asked her to be the icebreaker, and she graciously agreed. So appreciate that.
You're welcome.
So if there's any other questions from the audience, as you just saw, we can very easily unmute your microphone and you can ask those directly.
So while we're waiting, if I may, I just want to reinforce that if I'm speaking to a group of potential responders and or folks who oversee groups of responders, I expect, and I hope that folks are thinking about this and kind of taking an inventory about what they think the resources are now, being thoughtful about what the process that they would use is now, trying to understand how well they're educating folks, or they are educated about this, so that, left of boom, before people have to go out the door, we're as well prepared as we can be. Because this, to some extent, I think is something we're going to be faced with if we choose to go out the door, and something that I think we've done a very, very poor job of preparing people for, especially given the fact that we have good intervention for it, and we have good preparation and mitigation for it. So it's kind of shame on us for not taking advantage of something that we can do something about.
I do have a question. I guess it's a bit more of a comment that came over, and I think it's sort of ties into the EMDR. There's a comment here from Irene Champagne. I think I pronounced your last name correctly, and she mentions that emotional freedom technique also works extremely well in the wake of trauma. Just wondering if you had any thoughts on that, Dr. Kamin.
I don't specifically, and I'm absolutely transparent about the fact that that EMDR is but one of the interventions that have been proven to be useful. Again, I find I don't particularly find the controversy useful, because people don't argue that EMDR is not useful, just that it's not any more useful than some of the other studied interventions in cognitive behavioral therapy. I'm delighted that there's experience out there with others. I think that the use of the modality you choose, again, you should have an understanding so that you can apply the right tool when the job is needed. EMDR or any modality needs to be fit by a professional to the person looking for help, or the person who needs it. So what I would say is I'm delighted if this individual had good experience with another intervention, and I don't have any personal experience or comment on it.
I have a question for you, Dr. Kamin. Since your experiences at Sandy Hook, which occurred in 2012, has there been changes to what you described as the left of boom, like getting individuals ready for some of these situations they may see as a first responder, as a paramedic, EMT, police officer, etc., to prepare them more from some of the insights that you've had as a result of that experience with like law enforcement in Connecticut or other departments that you work with, either locally or regionally?
Yeah, I think that's an important question, and I'm happy to say the answer is yes. It's not universally applied or installed, but there are a number of initiatives that have come out from professional groups, both law enforcement, fire, police, physician groups, nurse groups, about the importance of resiliency and the importance of how much suicide and substance abuse, etc., how much these jobs take a toll on the folks who are doing them. So there have been not only broadly kind of discussed and implemented importance of resiliency, but locally, a lot of fire departments, police departments, and unfortunately EMS a little less so, but nonetheless, there are great examples of EMS wellness and resiliency programs that have been built up to try to help folks prepare before the event, to try to help folks who are exposed on a day-to-day basis, not necessarily to the big T, but definitely to a whole bunch of little T's, and help get folks the tools they need to address this on an ongoing basis. There's a number of great initiatives. There's a gentleman, Sonny Provetto, up in Vermont, that's doing great work with law enforcement at an agency he's created. And again, the community is building. One of the things I think would be great is to have a more consistently acknowledged standard for how we address this. And I know there are a lot of folks working on it. The Committee for Tactical Emergency Casualty Care is one of those groups that's trying to amass what might be a best practice, so it can be put out with the other guidelines and protocols that are put out as standard. But yeah, I'm happy to say that there has been some movement and a lot more to happen.
Great. Well, thanks for answering that. We did have a presentation a few weeks ago on trauma surgery in austere environments, and the presenter, Sean Smith, touched a little bit on some of the points that you raised in your presentation about having people who deploy on disaster response or humanitarian response type missions to provide medical and health care, that they are adequately prepared psychologically for what they may encounter when they're being deployed. So that was kind of touched on, and I see that there'd be a lot of similarities through just preparing, say, local law enforcement, first responders, to even, that could be applicable to people who would be participating in some of these deployments overseas with either emergency medical teams or through other sorts of missions, that some of that experience and insight would be quite universal. Anyhow, we do have another question that came in from Bruce Wenningman, and I think I got your last name pronounced correctly. And Bruce says, when you mentioned CISD sometimes not being effective, what are your feelings about CISM and the interventions being offered by the ICISF?
So, I'm not sure about the ICI. What was the last acronym?
The ICISF. So it's just this is why, if you want to ask the question directly, it's a bit preferable, so that any lack of clarity in me reading the question can be addressed. But anyway.
But while Bruce is deciding whether or not he actually wants to speak to us, that's okay. What I'll back up and I'll say that we have a very clear understanding that some of our traditional approach to critical incident stress debriefing that involved mandatory participation in a debriefing event, typically surrounded by the group of folks who were also there, is sometimes bad for people, as in causes more harm than it does good. And that is for a number of reasons, but one of them is clearly that you're taking folks who already had a different experience. Like I said, like, you're taking the folks who have only been affected by the fact that they heard it on TV too many times, right? Or maybe they were standing by at an event to try to take care of folks, and there were or weren't people to help. And you're mixing them into the folks that had an experience where they had direct hands-on experience. And if I was in a room and you asked me to describe what was upsetting at Sandy Hook, full of folks who may have had some involvement but not the same involvement, I might actually, through my description of what bothered me, provide these folks with more trauma than they were already subjected to. And the reality is that not everybody processes things the same, and that sitting around in a circle with a group of folks kind of going around talking about your feelings is not the right thing for everyone to do and could be more harmful to folks. So I'm just understanding that we are really revamping the way we look at critical incident stress debriefing. It's not that it's universally bad. It's that mandating a specific type of debrief and mandating participation with that specific type may not be good for everyone. I can't speak to the second part of the question just because, like I said, I had some uncertainty about some of the acronyms, but knowing that it's a mixed bag, and that we got to be ready to hopefully provide folks with a mixed opportunity so that they get what they need, not necessarily in the way that I think they need it, but in the way that's best for them.
Okay, thank you for answering that. I don't see too many other questions. We have another comment here. I think this was mentioned during the presentation on Sonny Provetto Center, the Vermont Center for Responder Wellness.
Yep.
So that URL was just sent to me via text. The URL is vtresponderwellness.com.
Absolutely.
That was from Gene Speck again. Thank you, Gene. I don't see any other questions. We did have a comment from Irene Champagne, who did ask about the emotional freedom technique, and she mentioned that Francine Shapiro is the developer of EMDR and has written a book called Getting Past Your Past, and she just wanted me to mention that. So if that's something that anyone on this call is interested in, from what Irene is saying here, is that she's one of the founders of that technique, and that book might be of use if you have interest in learning more about it. I guess if we don't have any further questions, we are at kind of the hour point here, so we could, I guess, wrap things up. Did you have any final comments you wanted to say, Dr. Kamin?
Yeah, I wish I hadn't, that I wish I had asked you to call me Rich a long time ago. And that's fine moving forward, although I guess we're at the end. And again, the only thing I want to say is that, there's so much that we do to prepare to be effective when we respond during an event where our response might actually influence the outcome. And I think that as we do that, and as we work hard to do our job as best as we can, we really should not forsake the opportunity to prepare ourselves to be even more capable. Because I feel strongly that what I came out of after Sandy Hook, and the process I went through, didn't break me, and it allowed me to continue to be, a dad and a physician and a responder and a friend, and to continue to do all the stuff that I want to do and I feel strongly about. So, speaking to a community of folks that I would imagine are passionate about maintaining their ability to respond and doing it well, I just think this is a great opportunity to do it. And I think someday we're going to get so that culturally we'll be able to change the focus on folks' response to this, so that people understand it really is a normal kind of response to an abnormal event, and that folks who have that response will not be considered weak or possibly less than. It's just going to be an expectation and something that we will anticipate and be able to address.
And I'd also like to thank Rich for doing this presentation for us. I'd like to point this out, that this was, I think I'd have to go back and look at total attendance numbers, but the second best attended webinar we've had. So thank you to everyone in the remote audience for being on the webinar today. I know depending where you are in the world, it could be very early in the morning or perhaps very late at night. I did see a few names I recognize, some of our colleagues from Australia, and I think it's not the best time of day to be listening in on a webinar, so thank you for that support. As I mentioned at the beginning, we'll send out an email to everyone letting you know when the slides and the recording are available online, and we'll also share Dr. Kamin's email address with everybody and let you know when the next webinar, the last one of the year, will take place as well. And Rich, thank you again. This is something that we have people do as a volunteer, and we really appreciate you taking your time and sharing your expertise with Wadham and with everyone in the audience. And one last bit, I want to thank Fadi, who did the introduction, for doing the introduction, but also for making the connection with Rich here to help bring this all together. So thanks to both of you a lot. We're very appreciative of your help and support.
Yeah, absolutely. My pleasure. My pleasure. Thanks for having me.
Thank you, Rich.
With that then, I want to thank everyone again for supporting and participating in the webinar today, and we will let you know about everything via email. Everyone have a good morning, afternoon, evening where you are, and we'll speak soon.
How did you meet him, buddy?